Hi, I'm Justin Riley. Today on Wisconsin Doctors, part 2 of our series here at Upland Hills Health, talking about the opioid epidemic. We'll be joined by Dr. Rachel Hartline from Family Medicine and Dr. Charlie Pierce from Madison Emergency Physicians, and we're going to discuss everything from addiction to dependency and what to do if you suspect that you or someone you might know might have a problem with either illegal or prescription opioids. It's all coming up right here on Wisconsin Doctors. Stay right here. Welcome back to Wisconsin Doctors. We are here at Upland Hills Health, and last month when we were here, we were discussing the opioid epidemic, and we're going to continue that conversation today. And I have a couple of fantastic panel members that are going to shed some light on the subject, including Dr. Charlie Pierce and Dr. Rachel Hartline. Welcome back to the show.
Thanks.
Always good to have you on.
Thanks for having us.
Yeah, always good to have you on Wisconsin Doctors. So, for those who have not seen last month's episode, tell us a little bit about the opioid epidemic. What is it?
Sure. So, it was pretty well captured in the last episode, so worth taking a look at it. People had a chance to see the last episode. But basically what the opioid epidemic is, it's in the last 10 to 15 years, there's been an incredible surge that we've seen in opiate abuse, misuse, overdose, and deaths. And so what this encompasses, to try to give people a sense of kind of get their minds around this, in the last 15 years we've had about 500,000 people that have died as a result of opiate overdoses. So that is a city the size of Minneapolis of people and individuals that we have lost in the last 15 years. Those are your neighbors, those are your spouses, those are friends, those are other people in your community that have died as a result of and largely accidental overdoses in terms of opiate medications. So it is, and in that 15 years, you go back 15 years, we have quadrupled. So we have 4 times the number of deaths in 2014 that we had back in 2000. So the scope of it is just A, huge, and B, continues to be a rapidly rising population of people that are affected by this.
And can you describe for us the difference, just to clarify, the difference between opiate and opioid?
Sure. So the best way to look at it is, so opioids are generally pain-related medications that are derived from, the basis goes back to a poppy plant.
Sure.
They can be synthetic or non-synthetic. Opiates are specifically talking about those medications that are largely the non-synthetic. So that's going to be your morphine, that's going to be your initial derivatives. So it's a subtle difference between the two, but an important difference that one can note.
Sure, yeah. And it seems like, you mentioned Minneapolis as being, that's pretty staggering to think of that one day, the city of Minneapolis just being a ghost town.
Yeah,
just essentially, it's just gone. This seems like you'd think this would be a problem in more urban areas like Chicago or Milwaukee and maybe even Madison, but not so much in rural America. I mean, is this a problem in Iowa County?
Oh, it is a much bigger problem in rural areas than it is in cities. Just to give you a sense of the scope of this, is that back 2 years ago, the governor of Vermont, Shumlin, spent his entire state of the state talking about the opioid epidemic that's affecting his state. And that's a state that's effectively a rural state. And as he spoke to the idea that this is something that affects rural counties across the nation in a profound way. And you're actually 45% more likely to be affected if you're in a rural county than you are in the city. While the numbers play out, because we're such a urban population now, 80% of us in the United States live in a city, the sheer number of volume is going to affect people in the city greater, but the actual per capita, percentages that you see are greater in rural areas. So absolutely, Iowa County is affected.
You have a bigger chance of being affected by it if you're in a rural county.
Yep,
yeah,
exactly.
And we've all seen the picture of the grandparents that were passed out in the vehicle from a heroin overdose, and the 4-year-old in the backseat. Yeah. And I mean, that was in a rural area,
Ohio.
Eastern Ohio.
Yeah. Exactly.
Yeah. So is the problem more prevalent, if I can get the word out, prevalent in a certain age group or class or social class? What are you seeing?
So it tends to disproportionately affect non-whites, is what we're seeing. It also affects people between the age range of about 20 and 45. In terms of deaths, that's about 2/3 of people are between age of 19 to 45. In terms of deaths, the greatest and most affected population is going to be people in their late 20s to mid 40s.
Late 20s to mid 40s. Wow. Okay. And how do you think this problem came about, and why is this happening now? Why is this in the last 15 years have we seen this?
Oh, that's a big question. So
let's take a short break, and I'm going to ask you that question again when we come back from the break. We're talking about the opioid epidemic here on Wisconsin Doctors here at Upland Hills Health. Stick around. Welcome back to Wisconsin Doctors. We're talking about the opioid epidemic that's been so prevalent in our culture in the last 15 years here at Upland Hills Health. And Dr. Charlie Pierce, when we left before the break, I'd ask you the question, why is this problem coming about now? Why has this been happening in the last 15 years?
So to look at it kind of in a really big lens, to zoom way out, about 15, 20 years ago, there's been a rapid increase in the development of opiate medications. And those were fairly heavily pushed within pharmaceutical industry, that this idea that we use pain as the fifth pain scale and we need to really eliminate all pain. And so as a result of that, that has really driven prescription patterns. So you've seen, not only have we seen a quadrupling of the amount of overdoses, but in the same time we've seen a quadrupling amount of prescribed opiate or narcotic pain medications. And so those track, perfectly as you see the curves of both prescription patterns as well as overdoses. And so as that momentum has moved forward, physicians can continue to prescribe opiate medications, and then those overabundance of prescriptions have led then to subsequently to abuse for a variety of reasons. And one was for David Kessler, who's used to be president of the FDA or head of the FDA in the late 90s, said, we just under-anticipated what the effect of an opiate pain medication, and we believed data that said that these weren't addictive, which in fact they're quite known to be addictive.
That was going to be my next question is, people, in the industry, they had to have seen this coming, but clearly they didn't then. I mean, they were told that it was not addicting, or it wasn't as addicting as they thought it was going to be. And
you'd like to assume that there was good intentions along the way, that the goal was to try to eliminate pain or manage pain in an aggressive pharmaceutical-based strategy. But it depends how you ask. It's fairly controversial when you look back on it. When people argue one way or another how much was known or not known.
Dr. Hartline, you're not off the hook just yet. So obviously something has to change here. Otherwise this is going to continue to at least stay the same, if not get worse. There are new national guidelines surrounding the prescribing of opioids for chronic pain. Can you talk to us a little bit about what those guidelines are? What's the buzz around those?
Yeah, absolutely. So kind of recognizing that this is a huge problem, I think, the Centers for Disease Control, or the CDC, took a look at, what we know about these medicines and how to use them safely, and if you can use them safely. And so that's the first thing that I want to point out, is that it is kind of a set of guidelines from the CDC. A lot of, some reporting around this and the way that it gets talked about is as a legislative thing, like someone's telling your doctor they can't prescribe this medicine, and that's not the case. But it's looking at, when is it safe to prescribe this, and making sure that we're optimizing the health of patients. So the CDC released these new guidelines, and they sent this out to primary care providers all over the country. It's a little card that kind of goes through those guidelines, kind of summarizing the evidence that we have for the appropriate use of opioids. And I think the main focus you'll see is kind of a shift from treating pain as a number to optimizing patients' function. So, like Dr. Pierce said, there's a quadrupling in the number of prescriptions available, but since 1999, we've been kind of tracking those pain numbers, and nobody's pain number has gone down. We've put so many more of these addictive substances into the world, but haven't seen any kind of benefit in people's day-to-day lives, and in fact, we've seen more people dying and having horrific outcomes from them.
Right. So I'm trying to understand those numbers. You had it basically, if you take all the people who have chronic pain and they give their pain a rating on a scale of 1 to 10, what is the average pain level, or what's the data saying about what people are experiencing in terms of pain? And that has not gone down since this has started. Wow. Yeah. That's pretty staggering.
It completely is. I mean, and I think that it's just really, I'm like disregarding my Hippocratic oath if I continue to contribute to that trend.
Right.
And so that's why this has shifted and why there's so much discussion about it.
Right, because the new knowledge out there, we know that this is obviously not helping people like
Right.
we thought it would.
Right, and there are patients who have benefit, and so that's why why we still have these medicines around. But I think on the whole,
Right.
We need to make sure we've exhausted all the other options
Right.
and making sure that we're prescribing them in a safe way.
Yeah, absolutely. We're going to take a short break, and when we come back, we're going to continue our discussion about the opioid epidemic here at Upland Hills Health on Wisconsin Doctors. Stay with us. Welcome back to Wisconsin Doctors. We're here at Upland Hills Health in Dodgeville discussing the opioid epidemic. This is part 2 in our series of 2 episodes about this topic. And Dr. Rachel Hartline, we just got done talking before the break about how things need to change. And, the caregivers or the primary care physicians and whoever's prescribing these medications need to sort of be stewards of this and really make sure that they're prescribing them to the people who truly need them. So my next question is, what are patients going to see in the future? How is this going to affect the care that they're receiving?
Yeah. So the bottom line is that, as your physician, we still have your health in mind, and we want you to be, we want you to be functional, and we want you to be as comfortable as possible, but we want to do that in a safe way. So I think you'll see a focus on kind of alternate medications to opioids to treat your pain. So there are a lot of other medicines for pain that aren't addictive that sometimes can have greater outcomes.
Sure.
Can make you more functional and can improve your symptoms. And so we'll focus on those things before moving to the opioids. There's a lot of patients out there who are already on them. And so in that circumstance, kind of making sure we do frequent assessments of, are you really benefiting from these medicines, or are they just something that you've been taking and having, you're at increased risk, but they're not really making your life any better. And in
Right.
that case, we work on decreasing the dose and hopefully eventually getting someone off of those medicines. And then the other thing is that, I think that making sure that we're assessing the risk appropriately involves more surveillance, I think, than people are used to. And it's not nothing against any patient, but there are these drugs that are being diverted in the community. And we have to make sure that the ones that we're prescribing are getting to the right place. So
Yeah.
you'll see more urine drug screen testing, and that, again, that's not a statement of I don't trust you. It's a statement of this is a controlled substance, and I need to be careful where it's going. And so that's
Right.
something that's happening with all of my patients.
Yes, absolutely. So, Dr. Charlie Pierce, I want to move to you for a second here. We're talking obviously about addiction here. A big part of this is addiction. People get hooked on these drugs and they can't stop. They have no control over what they're doing. So, but there's a certain level of dependency there as well. So can you help us understand the difference between dependence and addiction?
Sure. So the key to understand this is know that addiction is really nested within dependence. So dependence is a physiologic change that happens as a result of a person being repeatedly exposed to a medication in this instance. And that physiologic change can be mental, it can be related to the gut, it can be related to other systems of our body. And so that's simply when you remove that medication or substance, then a person has withdrawal because they become physiologically dependent on it. You take addiction is nested within that because dependence is there as well, but addiction is the really harmful extent. So a person who's got a compulsive behavior that continues to use a substance despite the fact that it's causing harm to them. And that harm can be physical harm, it can be social harm, it can be psychosocial harm. So really to understand is, there's a dependence component, and within that dependence you have a rate at which you see addiction or abuse or misuse as well.
And I think I remember one of the previous, I think it was Dr. Berg last month, had said, very simply put, taking heroin as an example, the brain loves heroin more than it loves oxygen.
Yeah, I think that was Dr. Hansen.
Dr. Hansen
yeah,
said that,
mentioned
okay.
that, and he's exactly right that you have this, when you person, and I'm no addictionologist,
Right.
I'm an ER doctor, but a person who becomes addicted is, that becomes their primary goal when they
That's
get up in
their
the morning.
primary
That's their
focus.
primary goal when they go to bed at night, and everything else falls aside. And that's essential to defining addiction.
Yeah. So you said obviously you are an emergency physician. So how is this affecting your emergency department? I mean, what are you seeing in the emergency room?
So we're the primary place in which an overdose presents. So when we have been seeing a huge uptick thus, and the people are coming in with overdoses from these medications, we're the ones who intervene and take care of people who've overdosed, and we're the ones who can try to resuscitate them, bring them back, and we're the ones who kind of directly expose the folks who then die as a result of an overdose. But in addition to that, as Rachel kind of alluded to, we also play a role in the prescribing pattern. So we also prescribe opioid pain medication that we use for a variety of reasons. And so we are also a place in which patients who are attempting or hoping to get pain medications will come to us, and you can have misuse of the emergency department in that regard.
Sure.
That's certainly a trend that we've seen, and a trend that we really worked diligently to try to cut into.
People coming into the emergency room trying to get those pain meds because they think they need them.
Right,
Yeah.
and because they're dependent and they have addiction, so that kind of drives their behavior as well.
Yeah, absolutely. We're going to take another break here. When we come back, we're going to conclude our discussion about the opioid epidemic here at Upland Hills Health on Wisconsin Doctors. Stick around. And welcome back to Wisconsin Doctors. We've been discussing the opioid epidemic here at Upland Hills Health. And Dr. Pierce, because you are an emergency physician, I want to ask you this. If people come to the emergency room for whatever issues, how do you help people who come in either because they're having symptoms of addiction or dependency of opioids, or they perhaps may be on the verge of an overdose? How do you help those folks?
So the way I view it is there's kind of three buckets. There's the first bucket is a person who's coming in who's an acute overdose. So that's a person who's an ingestion, intentional otherwise, and overdose on that medication. In that case, we had to intervene right then and there in a kind of a life-saving manner. And that's the use of Narcan, naloxone, which was talked about in the last segment. That's kind of the antidote. And so that that's the immediate urgency of getting a person to start breathing on their own again. The second bucket is you have people come in who start going through withdrawal because they're dependent, and whether they are intending to or not intending to withdraw from these medications, they come in because they need help and to have assistance in getting through the withdrawal symptoms. And so we can provide medication and certainly guidance and helping a person manage withdrawal. Fortunately, withdrawal is not life-threatening for opioid pain medications, but it's discomforting for those who are going through it. Then finally, we have people that come in who simply are asking for help. And so we have sources that we can point people to that can provide them the long-term help that they need. In all those instances, we try to give the person and point them in a direction towards long-term solutions. But those some people just simply show up because they say, I've got through withdrawal, but now I don't know where to go. And so we can be a safety net for people in that instance.
And you mentioned Narcan, and something that kind of triggered my memory from last month's show, and I think this will be a good segue into what Dr. Hartline wants to talk about, is that, even when you take Narcan, as the antidote, that doesn't stay in your system as long as the opioid does.
Right, exactly.
So it's important to realize that even if you're not in the hospital and a friend of yours is overdosing, you give them Narcan and they start breathing again, it's still important to get them to the hospital.
Absolutely. The half-life that you see of something like heroin is going to be hours longer than you're going to Narcan. So you got to come in because you may need to have additional doses. You may even need to be admitted to the hospital to be observed because of these really long-acting opioid pain medications. Yeah,
absolutely. Dr. Hartline, if a person is recognizing that they have a problem with heroin or maybe even a prescribed opioid, what can they do?
Yeah.
What are the first steps?
So I think the first step is to talk to a professional that you trust. There's been a lot of stigma in the past around mental health in general, and especially around addiction issues. But I think that that is shifting away. And I think at the end of the day, your primary care doctor is there for your health, and they're going to be supportive of you in this. Addiction is just like any other chronic disease. It has behavioral sort of inputs into it, but it deserves to be managed in that way. And most doctors, I think, at this point are in the place where they're working under that paradigm. So you can trust your doctor, and if you can't, you come to me. But they want to see you're healthy. I think that when you're kind of operating under that paradigm, it's important to realize that there are behavioral inputs to this, and there are chemical things that are happening in your brain. And so a treatment approach that is effective is going to take both of those into account. So you're going to have people people in your life while you're in treatment for this issue that are working on the behavioral side of things, like seeing a counselor and things like AA and NA. And then there are kind of medicines we can use to help. And it's a little bit beyond the scope of what we can talk about today, which one is appropriate for you and things like that.
Right.
But just sort of to summarize, there are both replacement medicines, things like methadone, and then buprenorphine is one that's more available in rural areas, or one that we're working to make more available in rural areas, as well as things that actually directly counteract the opioids and keep you from being able to get high on them. And in addition to sort of the life-saving sort of intervening measures like Narcan or naloxone.
Right.
So there's this whole spectrum of treatment options that I think it's important to take into account, but that's the kind of discussion you may have with your doctor. And then the other point I would say is, like, if you're in a moment of crisis, there's a national number set up by the Substance Abuse and Mental Health Services Administration that's available for folks to call, and then there are also more kind of local resource numbers.
And we're putting those numbers up on the screen, so if you know somebody or if you suspect that you might have a problem, be sure to call those numbers right away. What about if you suspect a friend or a family member has a problem or needs help?
Yeah.
That can sometimes be a sensitive issue because we want to try to get in and not push them away and not turn them off and shut them down. We want to make sure that we can kind of get it. What do you think is the best way to approach somebody like that?
Yeah, I mean, it's never an easy conversation, but it's important to be honest with the person about your feelings, to be non-judgmental, to understand that it is a disease, and if you can provide sort of specific examples of the behavior that you're concerned about. Any conversation that's confrontational tends to go better when you can provide more specific examples.
Yeah.
It's also nice to go in with a sort of next step or solution. I think you have this problem. Why don't we set up an appointment with your doctor, or why don't we set up an appointment with a behavioral health professional to talk more about it? It's important to be supportive of those people and let them know you're there when they're ready. It's not having that conversation doesn't always result in the outcome that you want, and that's not your fault. You can't make someone become unaddicted to something if they're not motivated to. But sort of supporting them in that. And then the other important thing is to support yourself. It can be super stressful, and you can feel a lot of guilt around these things. Again, it's not your fault, but sort of that dynamic is difficult. And so there are support groups for persons who are loved ones of folks with addiction. So that's things like Al-Anon and Nar-Anon. So just kind of being aware of all those things, taking care of yourself, and making sure you're there for your loved one.
Yeah, absolutely. Dr. Rachel Hartline and Dr. Charlie Pierce, thank you so much. This has been a great series of shows, been very informative, so thank you so much. And thank you for joining us here today on Wisconsin Doctors. If you know somebody or you feel that you may have a problem, feel free to call the number on the screen and they can get you the help that they need. That's all the time we have for Wisconsin Doctors. From all of us here at Upland Hills Health and Wisconsin's 57, we invite you to live longer, live better. We'll see you next time.